Monday, the 29th of April, 2021. You are assigned to the emergency room. It is 10 a.m., and the ambulance brings in a male patient, approximately 44 years old, with a known history of cirrhosis and chronic alcoholism. The patient presents with serious complications and clinical manifestations. The attendant indicated that while en route to the hospital, the patient vomited copious hematopoiesis. You note that a kidney basin next to the patient is full of blood. The patient's significant other indicate that he was vomiting for 3 days, which started off as grounds and progressed to bright red. Moderate chest discomfort and nausea. He insists that he is okay and just needed something like a beer to drink.
Good afternoon, Dr. Abley and my fellow colleagues. I'm nursing student Flora Mott, and today I will be presenting on Mr. D medical history.
Mr. D is a 44-year-old male who works as a security guard for the past 10 years, has two grown children, and lives with his common law wife for the past 8 years. Mr. D was brought in via ambulance with the complaint of vomiting for the past 3 days. We started off as grounds and progressed to bright red. Moderate chest discomfort and nausea. Personal data. Date of birth, July 10, 1957. Marital status, common law. Has two grown children. Employed as a security guard for the past 10 years. Religion, Baptist. Nationality, Bahamian. Native language, English. Next of kin, in case of emergency, Mary Sue. Address number 5, Rosewood Street. Telephone number 339-4501. Past medical history. Cirrhosis for the past 2 years. Past surgical history, none. Allergies, none. Social history. Patient lives in a two-bedroom wooden house, which occupies 3 persons, including himself, his common law wife, and one of his grown sons. Has indoor plumbing. The water sources from the city. Hobbies, playing dominoes with his friends. Immunization, up to date. Drug habit, none. But patient smokes cigarette, one pack a day. And also patient claims that he drinks about 6 to 12 beers a day. And sometimes will have coconut rum with Coke. Mr. D is a 44.
Good afternoon. My name is nursing student Shaniqua Stubbs. I will briefly speak on the etiology of our clinical diagnosis, and this would have already been established as the esophageal varices. Now, we have three primary causes of the esophageal varices. The first one would be the cirrhosis of the liver, and we would already know that cirrhosis would be defined as a late stage liver disease. Now, with this disease, it's going to be presented where healthy liver tissue is replaced with scar tissue, and eventually the liver is going to be permanently damaged. Now, we know that scar tissue is going to keep your liver from working properly. Now, if you look at the A and P of the liver or of any organ, you would know that once a problem is presented, then this is going to inhibit the function of that organ. So with the cirrhosis, we see that happening here. So basically, each time the liver is injured, in this case with our patient, he's using alcohol consumption. The liver it's trying to repair itself, but with this constant consumption of alcohol, the healthy liver tissue doesn't have enough time to replenish itself. Therefore, these tissues are then scarred, and the patient is now left with cirrhosis of the liver. The second cause, we would point this to be alcoholism, and we would define this as an addiction to the consumption of alcoholic drinks or beverages. Now, this would basically be where you see a patient presenting or precipitating alcohol dependency. Now, our patient would have came in and he would have stated that, he would just need a beer just to feel okay. That there indicates some characteristics of an alcoholic, because now he's thinking that if he has a beer, he's going to be okay, he's going to be fine. And then in this case, we know that is a far cry from him being okay. So our third cause would be noted as portal hypertension. And with this, we would say that it is an increase in the pressure within the portal veins, which usually carries blood from the digestive organs to the liver. Now, the normal portal vein pressure range would be from 5 to 10 milliliters of mercury. Now, you might be saying this doesn't seem as a lot or a large number, but when you put that into perspective of looking at the veins that run along the stomach or the esophagus, this is going to be a great deal of pressure to these veins.
At this time, we would already know that our patient is presenting with a gastrointestinal bleed and he has esophageal varices. So at this time, we would know, after our physical assessment, we would know automatically that we need to do a focus assessment on the gastrointestinal system. So the first thing that we need to do is to ensure our safety considerations, and by this I mean we're performing hand hygiene, you're checking the room for contact precautions, you're introducing yourself to the patient, because you don't want to just walk up and just come to the patient and do what you have to do, go through with the assessment and don't introduce yourself. You want to confirm the patient's ID using two patient identifiers. So that would be the name and the date of birth. So like I said, you want to explain the process to the patient, but like, good afternoon, my name is nursing student Stubbs, and I am here to conduct a focus assessment
and you ask them for permission as well. So you want to be organized and systemic in your assessment. You want to use appropriate listening and questioning skills. You also want to listen and attend to the patient cues. So we have our patient as well as his historian, his wife. So this is going to be additional information to us. We also want to ensure that we provide privacy and dignity to our patients. So we're going to screen our patient bedside. We also want to check the vital signs. We want to make sure that we have everything in order, and we would like to complete the necessary focus assessment. So we want to do a thorough completion of this assessment. So moving right along, we would want to conduct a focus interview related to the gastrointestinal and the urinary system. So what we're going to do in collection of the history, we're going to ask our patient if he's able to, if he is conscious. We're going to ask our patient. We can ask his historian, which is his wife, his next of kin. We can ask if there was changes in appetite. Then we have any weight loss or gain, any dysphagia, that's difficulty swallowing, any intolerance that he would have encountered while eating certain foods, any nausea, vomiting, any changes in the bowel habit, as well as abdominal pain. Now, when it comes to abdominal pain, we want to use our mnemonic of the PQRSC. Now, we know that our P is the provocative or palliative, Q is for quality, the R is for region or radiation, S severity, and T for timing. Now, with P, you want to ask questions such as what makes the pain worse, or the pain or the symptoms worse or better. With our quality, we're going to ask our patient to describe the pain or the symptom. With our region and radiation, we're going to ask where in the body does the pain or symptom occur, or is there radiation or extension on the pain or symptom to another area of the abdomen. Moving on to the severity, we're going to ask on a scale of 1 to 10, 10 being the worst, how bad is the pain of the symptom. Then we're going to ask the patient, this is going to be in reference to the appetite. We're going to ask the patient if they had any changes in the appetite. You want to ask them if they did any further investigations with the changes that was noted. You want to ask them if they had any changes in weight, if the weight was investigated to see if there was a loss or a gain. Or you also want to ask if this is an intentional weight gain or an intentional weight loss. We're going to ask if any difficulty swallowing when difficulty swallowing, as well as when it was first noted. We're going to question if any aversions to intolerance is eating specific to any food, so like allergic reactions or anything of that sort. We want to ask and question if the patient experiencing nausea and vomiting, and ask about the frequency, the color, and the odor. We want to ask if blood is present, and if it is present, we want to ask if it appears as coffee grounds. Now, we also want to know the frequency, color, and the consistency of any bowel movements if noted. And you want to ask if the patient has been using any laxatives. So, at this point, you want to have the patient point to the exact spot of the abdominal pain. And you want to ask if the patient had any past abdominal GI history, or if any medication history is present. Following through with the assessment, we're going to do an inspection. We're going to inspect the abdomen for any distension, striae, scars, contour, and the symmetry. We also want to observe any abdominal movements associated with respirations or pulsations of peristaltic waves. The next thing we're going to do is to accustulate. So we're going to accustulate the abdomen for bowel sounds in all 4 quadrants. Then we're going to move on to palpate the abdomen. We want to do this very lightly as well as in all 4 quadrants. Lastly, we want to note that if our patient is wearing any underwear, we want to ensure that he's clean and dry. And you want to inspect the skin underneath for any signs of redness to see if there's any rash or breakdown of the skin. Now, if our patient, later on we'd know that a Foley catheter will be inspected. So with this, you want to inspect the bag for the urine, the amount, color, and if there is clarity. Now, you also want to inspect the skin at the insertion site to note if there is any redness or breakdown. And lastly, we all know that once we have fallen through with this assessment, we are going to report and document our assessment findings. Now, in regards to our patient, we will know that at the time our patient appears very restless or he's in and out of consciousness. So a good thing that we would say is that we have the patient's history and his wife. So with this focus assessment and the initial assessment being done, we're able to still collect a bit of information, but it might not be as thorough, or our questions might not be answered exactly how we need it to be. So for the changes in appetite, we would have noted that our patient would have stated that he isn't eating much as he would like to be, or he isn't eating as much as he used to be. Now, in regards to the weight loss or weight gain, he would have stated that he noticed, around the abdomen area, that there seems to be a bit of weight gain. Now the patient or the historian, they don't know the exact weight, so we have to do an estimate. Now, with the difficulty swallowing, our patient stated that he didn't really experience any of these symptoms. Now, with the intolerance of certain foods, our patient stated that everything seemed fine and okay. Now, with nausea and vomiting, our patient did stated that he does experience, the wife states that he does experience nausea and vomiting, especially after drinking alcohol or consuming alcoholic beverages. In regards to his pain in the abdomen area, in regards to it being better or worse, he stated that, once the client is, already in an intoxicated state, that he appears to be, or he states that he's just fine. He states that, once he lays down in a comfortable position or sitting upright, that it all appears okay. Now, when asked to describe the pain, it wasn't a clear definition of how the pain would be described or how it would come off towards this patient. Now, our patient did state that he does not experience any radiation or extension of pain. He would state that he does experience the pain in the abdomen area, and on a scale, he would state that sometimes it'd be between 2 to 4. Now, in regards to the frequency, color, and odor of the vomit, as well as nausea, he stated, like I said, once the patient is intoxicated, now we know that this patient basically on a daily basis, he's consuming about 6 to 7 beers a day. So he does experience nausea frequently throughout the day, constant vomiting, and now prior to hospitalization, his wife states that he was vomiting coffee-colored grounds, but now it's appearing to be a bright red color. Now, with the frequency of the color and consistency of the bowel movements, our clients, the wife wouldn't know, or the wife did not have knowledge on these frequencies or the consistency as well as the color, but our patient was able to state that he's not having a frequent bowel movement, and even when he does have a bowel movement, it seems to be very off. He states that it would be a dark color, a dark gray, clayish color, and be in the shape of pencils. Now, when we asked if the client would use a laxative, his wife did state that sometimes he would drink prune juice. He would drink a 8-ounce cup of prune juice, followed by a cup of water with that, either that or he would follow the instructions on the bottle of milk of magnesia. When we asked our patient to state or to point to the exact spot on the abdominal pain, he basically, was groggy and seemed very out of consciousness. He basically pinpointed the whole abdomen. When we asked about any past abdominal GI or history, we noted that, the wife noted that he does have cirrhosis of the liver and any medication history stated that he is not currently on any medications.
Hi everyone, my name is student nurse Ludi Etil and I am a part of group 1 stimulation assignment.
Labs were drawn for this patient at about 11:30 a.m. that morning, and the results for these labs came through at 5:30 p.m. Doctor ordered a liver function test, renal test, and full blood count, and also ABGs to be done for this patient, and also his blood should be cross-matched.
Good afternoon. I'm student Juva McPhee, and I'll be talking about diagnostic procedures.
Diagnostic procedure. The patient was taken to the X-ray department for chest X-ray, abdominal ultrasound, and CT scan of the chest and abdomen at 12 p.m. Large varices were visible on the chest X-ray and the abdominal ultrasound. Patient is NPO for emergency endoscopy.
Good afternoon. My name is student nurse Monisha Kalmar.
This is student nurse Kalma, and in this section of the simulation assignment, I will be discussing the nursing management. There are several general measures that must be performed when a patient is admitted into the emergency department. For our patient, we have established 2 large bore 18-gauge peripheral IV access to allow rapid infusion of blood products and fluid. During this time, we would also draw blood for laboratory investigation and provide 6 liters of supplementary oxygen via nasal cannula to the patient. A Foley's catheter was also inserted for the purposes of strict intake and output monitoring and charting. The patient was also placed on a continuous cardiac monitor to monitor for dysrhythmias and accompanied by a 12-lead ECG which showed sinus tachycardia. The head of the bed was elevated to a high phallus position and the patient was maintained on an NPO status to prevent aspiration. All non-steroidal anti-inflammatory drugs during this acute phase was placed on hold due to the presence of an upper gastrointestinal bleeding. A mental status assessment was also performed, and the patient scored a 13 on his Glasgow-Coma scale. The eye-opening response to speech scored a 3. The verbal response scored a 4, which indicated some level of confusion, and the motor response to command scored a 6. A Glasgow Black Badge score was also performed to predict the need for a blood transfusion and endoscopy. A partial physical assessment was also performed to assess for signs of edema and skin temperature to rule out pallor and cyanosis, which are signs of poor perfusion. The class of blood loss was also determined based on the amount of blood absorbed and estimated in the kidney basin. We know that the kidney basin can hold approximately 700 ml of fluid. And the vital signs were also assessed during this time. The heart rate, which is 112 beats per minute, indicates tachycardia. The blood pressure, which is 102/62, was in normal range. The respiration, which is 24 breaths per minute, is elevated, and the oxygen saturation, which is 95%, at present indicates that there is sufficient oxygen within the blood. The temperature is 97.8 degrees Fahrenheit, which is in normal limits, and also indicates the absence of hypothermia. The glucose is 70 millimoles per liter, and as mentioned previously, the GCS is 13. Therefore, according to these findings, the patient was classed into Class 1. Additional nursing interventions included warming IV fluids to reduce shivering and to improve patient comfort. After the 1-liter bolus crystalloid IV fluids was administered, the lung fields were assessed for crackles or rales to prevent fluid overload. The patient was also confined to bed to reduce oxygen demand and to conserve energy. Safety measures were also ensured by ensuring that the side rails were up and locked. We also provided ongoing assessment, such as assessing for ecchymosis, epistatus, petechiae, and bleeding gums. The level of consciousness and vital signs were monitored every hour, and urinary output to evaluate fluid balance. During blood transfusion, the patient was also monitored for any signs of reactions. A focused GI assessment was also performed to assess the bowel movement, ascites, colon and Turner sign, and any obvious bleeding in the skin, such as ecchymosis, hematoma, and also any guarding of a particular area and rebound tenderness. The patient was weighed for baseline data and to ensure that the patient is receiving proper nutrients. We also provided a restful environment by, as much as possible, limiting the amount of noise within the immediate area of the patient. We also apply compression hose to provide pressure to the lower extremities and to help maintain blood flow and to reduce discomfort and swelling. In the event that the temperature drops due to ineffective perfusion to the skin, we would provide the patient with a thermal blanket. At this time, we also provided psychological support to the family as well as the patient. We also like to obtain at this time an informed consent, which is key, especially since the patient can become hypoxic and also anemic and may not be able to become aware or remember. So at this point, we would like to continue, can constantly reorientate the patient to person, time, and place, as well as any diagnostic procedures and treatments. While preparing fully cross-matched blood may take about an hour, in some laboratories, we would consider using uncross-matched or type-specific blood until the cross-matched blood is available.
Good day. I'm student nurse Kendra Knowles, and I'll be discussing the medical management. In management of the patient, the goal of treatment is to prevent more liver damage, prevent varices from bleeding, and control bleeding. So after we've accessed the patient, we're going to administer O2 at 6 liters via face mask, or 35 to 60% for spontaneous respirations. We're going to administer IV fluids, normal saline bolus, 1 to 2 liters, then D5 half normal saline over 2 hours at 150 cc's per hour. Maintenance rate for fluid loss. We're going to monitor vital signs every 5 to 30 minutes. Document the findings and report abnormalities. We're going to provide IV access ×2 and maintain patency with large bore 14 gauge to 16 gauge for medications and blood transfusion. And in the event of if one doesn't work, we use the next. We're going to categorize the patient for strict intake and output monitoring. We're going to order investigations, obtain investigations, CBCs, UNEs, ABGs, group and cross-match, lactate levels, coagulation studies, blood cultures, fecal testing, hemoccult blood studies, and then we're going to order diagnostic tests, ECGs, echo, chest x-ray, UNA, endoscopy, and colonoscopy. We're gonna get radiology, CT scan, abdominal pelvic scan, and then we're gonna access neurological status every hour for baseline data and order a psych consult because the patient is still asking for bail even though he's in unstable condition. Then we're gonna insert a small bore nasogastral tube unless contraindicated to gain access to the stomach and its contents. We're gonna administer medication, thiamine or vitamin B1, which is essential for normal metabolism and utilization for glucose. We're gonna give 50% dextrose for GF less than 70 mg/dl. Analgesics, morphine, 5 milligrams IV every 4 hours to treat moderate to severe pain. We're gonna give antibiotics, cetirizine, 1 gram IV once daily. It's a first generation antibiotic to treat bacterial infections and prevent infections. We're going to give antidiuretic, Lasix, 20 milligrams IV once daily, or stat, to treat ascites. We're going to give proton pump inhibitors, Nexium, 40 milligrams IV, to treat GERD, acid reflux, and ulcers. We're going to administer 2 units packed red blood cells or 2 units of platelets for blood loss and hemoglobin levels less than 7, and to prevent tissue hypoxia and anemia. And if all of this doesn't resuscitate, we're gonna use inotropic support if crystalloids and colloids do not resuscitate.
Good afternoon. My name is Student Nurse Dorset.
Our nursing diagnosis for our patient, Mr. Jaberg, are as follows. Fluid volume deficit related to excessive bleeding, and this is evidenced by weakness and decreased blood pressure. Upon entering the emergency room, it was reported that Mr. Jaberg was weak, and we also noted that he had lost 700 mils of blood, which is a very large volume of blood to be regurgitated, And so this is our priority diagnosis. And then we chose ineffective tissue perfusion related to GI bleed. And this is evidenced by low oxygen saturation. So we know that blood transports oxygen throughout the body. So it was a telltale sign that we got a low O2 sat of 95%. So we know that Mr. Jaberg his tissues weren't perfusing as they should. Then we have risk for aspiration related to GI bleed and intubation. And of course, if we have a patient who's regurgitating blood or needs to be intubated, then we know that there is a risk for aspiration. Lastly, we have anxiety related to fear of unknown procedure and consequences of GI bleed. And we chose this because this is the first time that Mr. Jaberg has been in hospital for a situation like this. So we're expecting that he's very anxious because he doesn't know how dire the situation could be. He doesn't know the procedures that are going to happen. And of course, there's a little bit of confusion as well coming into the hospital with low fluid volume. So we chose anxiety.
Now, initially, when we do our handover to the nurses for the 10 p.m. shift, we would state the name of our patient, Mr. Jaberg Doe, 44-year-old. Physician is under Dr. J. Jones Brown. And we would state which complaints that our patient came in with, and we note that he's been vomiting for the past 3 days with copious hematemesis, and his wife would have indicated that the vomiting would have started off as coffee grounds and then progressed to the bright red color with moderate chest discomfort as well as the nausea. Now we would have stated the patient's history. He has a history of the cirrhosis of the liver and chronic alcoholism, as well as our clinical diagnosis of the esophageal varices. We would state which laboratory investigations were ordered, and they were the liver function, the renal test, the hematologic, the ABGs, and we would state our abnormal findings, and they are as follows. The total protein, we have 28 grams per liter, low albumin, 28 grams per liter low, alanine transaminamase, the ALT 79 units per liter high, the aspirate aminotransferase AST 120 units per liter high, INR 4 seconds high, red blood cells 2.75 times 10, and that's going to be low. Platelets, we have 49,000 units per liter, that is going to be low. Hemocrat, low 23%, HCO3 18 milliequivalents per liter low. Prothrombin, we have 18 seconds, that's going to be high. Our total bilirubin, 20 milligrams per deciliter high. Bond, 50 milligrams per deciliter high. Potassium, 6.5 milliequivalents per liter low. Sodium is going to be 129 millimoles per liter low. White blood cells is going to be 19.6 times 10 over 3/1 high. The hemoglobin is going to be 8 grams per deciliter low, and our pH is going to be 7.3. With that being said, we would also state the medications that were ordered for this patient. Our patient is now on morphine 5 milligrams per hour every 4 hours, cetirizine 4 milligrams per kg IV every 12 hours. That would have been given at 11:15 a.m. Our morphine would have been given at 10:15 a.m., 2:15 p.m., 6:15 p.m. We have our Lasix 200 milligram IV OD once a day. That would be given at 11:15 as well. Our Nexium would have been a start order of 400 milligrams IV infused at 10 to 15 minutes, and that would have been given at 10:46 a.m. And our vitals that we are going to be passing down to this nurse, the night shift, is going to be a heart rate of 114 beats per minute, BP 85/52 millimeters per mercury, respiration of 26 beats per minute, or O2 start of 94%. Sinus rhythm is going to be elevated QT with a QT waves with 0.8. We have a temperature of 97.8 degrees Fahrenheit, glucose of 88 millimoles of liters, and we have our GCS score of 12, E3V, and E3, V6, and M5. Our patient is also on 6 liters of O2 via face mask. Now, for the nursing interventions, what we would have done is we would have established 2 large bores via peripheral IV access, 18 gauge. Blood was drawn, labs was done. We provided 3 liters of supplementary oxygen via face mask, and that's going to be 6 liters of oxygen via face mask, and that's humidified. Foley catheter was inserted. Our patient was placed on a cardiac monitor. We elevated the head of the bed to help prevent with aspiration. Our patient is to be NPO. We performed the mental status assessment, performed our partial assessment. We assessed for edema, field of skin, rule out pallor, stenosis. We wanted to rule out the poor perfusion. Then we determined the blood loss. Then we have further into nursing interventions. We warmed our patient's IV fluid. We're trying to maintain his normal thermia. We also would have provided extra blankets. After the 1 liter bolus crystallized IV fluid, we accessed the lung fields to ensure that no crackles and rales were present. We confined our patient to bed to try to reduce the oxygen demand in order to conserve his energy. We ensured our patient's safety by placing up the side rails and making sure they were locked. Now, we would have thoroughly monitored our vital signs every hour, performed our focus assessment, weighed the patient, provided the patient with a restful environment, applied compression hose to provide pressure to the lower legs. We would have provided our patient with blood products, the plaque red blood cells, the fresh frozen plasma, as well as the platelets as prescribed. And the patient would have noted to have no adverse reactions from the medications as well as the blood infusion. At this time, we would state that our patient is now in a critical state and that he is being left in the care of a registered nurse and student nurse Johnson. So our patient is now in and out of consciousness, and like I said, our patient state is going to be critical.
Good afternoon, class. My name is Student Nurse Newton, and my group members and I will be presenting on Tossard's the Point. My group members are Student Nurse Antonio and Student Nurse Lubin. Tossard's the Point is an uncommon and distinctive form of polymorphic ventricular tachycardia, characterized by the gradual change in the amplitude and twisting of the QRS complexes around the isoelectric lines. Tossard's the Point, often referred as Tossard's, is associated with the prolonged QT intervals, which may be congenital or acquired. So, in basic student terms, Tossard's the Point is the twisting of the ventricles. This is clinically manifested in our patient with dizziness upon standing, syncope, which is basically fainting, chest pains, and also palpitations. Our patient is a male, approximately 44 years old. He came in and he had a history of cirrhosis and chronic alcoholism. Now, for our patient to be considered an alcoholic, he is a male, so for men consuming more than 4 drinks on any given day or more than 14 drinks per week. For women, it's a little less, consuming more than 3 drinks on any day or more than 7 drinks per week.
Good day. Okay, so in bed 1, we have Mr. TB. He's 44 years old. He was admitted to the hospital on April 4th, 2021 under the consultation of Dr. J. Jones. At 3 p.m. on Hanover, we received a middle-aged male patient lying in bed in a supine position, conscious and alert times 3. He was orientated to date, place, and time. He was breathing spontaneously on room air. The patient has a hep block instituted in the right brachial vein. Right brachial vein. So at 4 p.m., the patient's vital signs were 98.8 degrees Fahrenheit. Respiration was 26 breaths per minute. Heart rate was 114 beats per minute. His blood pressure was 99/56 millimeters of mercury. His oxygen saturation was 93%. And his glucose was 90 grams per deciliter. His Glasgow Coma scale is 10. At 6 p.m., the patient's vital signs were 98.8 degrees Fahrenheit. His heart rate was 112 beats per minute. His blood pressure was 100/56 millimeters of mercury. His respiration rate was 26 beats per minute. His oxygen saturation was 93. His ECG rhythm indicated a QT interval of 0.6, which means that he had a widened QRS complex, and his glucose was 90. So at 12 o'clock, the patient had an ECG, and that indicated Tossard's the Point. So as previously stated, his heart rate went up to about 225 beats per minute. He had irregular heart rate, and the patient, so the doctor ordered that the patient have supplementary oxygen, magnesium sulfate at 1 to 2 grams in a 10 ml bag of dextrose water. And then after that, he wanted the patient to be put, and you'll do that for 5 to 60 minutes. Then the dosage will switch to 0.5 to 1 gram. And you're going to do that every hour. He also wanted the patient to be cardioverted. The patient had no visitors during the shift. Great. And Logan and I'll be presenting on the diagnostic investigations for Torsades de Pointes. So in our patient, it is mandatory that we do an electrocardiograph, codenamed ECG or EKG. And what this will do, this will measure the electronic activity in the heart. So in our patient, it's expected that we're going to see a heart rate of 200 to 250 beats per minute. And it'll also be an irregular heart rate. Also, you're going to see you'll see no P wave. So the P wave will be buried in the QR complex, which would mean that in the QR complex, it's going to be widened. So a normal QR complex is 0.06 seconds to 0.10 seconds. But in this case, our patient has a QR complex of 0.56, which means that there's an irregularity in the heart. And in this case, the heart is speeding up and it's going too fast. So we have to do something to get the heart to slow down. Then you want to do a chest x-ray to rule out any abnormalities in the heart. An electrocardiogram is another test that you're going to do on the heart, but in this one, you're going to look at it's basically looking at the ultrasound waves, looking at the structures of the heart, making sure that there's no structural irregularities. Another alternative that you can do is we have to correct the rhythm for this patient. So what you would want to do is do synchronized cardioversions via defibrillator. So what this is basically you're going to give the heart a low-grade shock in order to get the rhythm back to normal. Now the trick to Torsades de Pointes is that it could either go back to a normal sinus rhythm or it could go to ventricular fibrillation. Then you're going to do a cardiac profile on your patient, whereas you're going to check the troponin levels, you're going to check the creatine, the CKMB levels, which is tests the contractibility of the heart. And then another laboratory test that you're going to do is your renal profile. In your renal profile, what would be significant for a patient with Torsades de Pointes in this case, we're going to look at the potassium levels, which would indicate it should be low in this patient because low potassium levels indicate hypokalemia, which means, and that's one of the signs in a patient that has Torsades de Pointes. In addition, the calcium levels are going to be low, which indicates hypokalemia, and your magnesium levels are going to be low, which indicates hypomagnesemia, which all of these help with the contractibility of the heart. Anytime something is wrong with the heart, you want to first look at your potassium levels. And then, so in this case, there are three factors that you're going to look at. Your potassium, your magnesium, and your calcium. Then in your complete blood count, you want to look at your hemoglobin levels to see the oxygenation and your hematocrit levels. So you want to make sure that the patient is getting enough perfusion. If the heart is speeding up, that means the heart is working overtime. In our patient, you would see that his potassium levels are low, indicating that he has hypokalemia. His magnesium and the normal potassium level, some books say 3.5 to 4.5, others say 3.6 to 5.2. So this indicates that he has hypokalemia. And anytime that there's an issue with the heart, you want to look at the potassium levels, because that deals with the muscle contractility, so the velocity of the heart muscle contracting. So as you can see, as I stated, it's low, so 2.6, which indicates hypokalemia. Then you have magnesium, which has a level of 1.2, which is low, which indicates hypomagnesemia, and this is responsible for the muscle excitability. So then you have a glucose level of 486 milligrams per deciliter, and this indicates hyperglycemia, but not necessarily related to diabetes. This is related to the patient's history of alcoholism that can elevate the glucose level. Then you have a burn level of 10, which is normal. Your bilirubin is normal, but if the bilirubin was low given the person's alcoholism, then it will indicate liver damage, cirrhosis of the liver. The AST is elevated. Then you have a calcium level of 5.6 and a normal, which is low, which indicates hypocalcemia. And so you would know that your magnesium, potassium, and calcium, they go together. So that's how you would be able to further understand that this patient has Torsades de Pointes. The nursing diagnosis that we came up with for this patient is decreased cardiac output related to disruption of blood flow to the heart, as evidenced by the patient verbalizing that they're feeling dizziness when they stand, feels like the room is spinning, chest pain in the substernal area, palpitations. So the first thing that we would want to do, we want to assess the patient's vital signs. Not only specifically, we're going to specifically look at the pulse, the respiration rate, and the blood pressure. With persons that have dizziness, syncope, you will see that their pulse rate will increase, indicating tachycardia, and their blood pressure begins to drop, and the respiration rate increases. Then you would want to monitor the lab results, examining the potassium, magnesium, and the calcium, which in this case of the patient, it will indicate that they all will be low, and that will be the reason why the patient is in Torsades de Pointes. Next, you want to assess the severity of the chest pain. Asking them the rate of the chest pain, the area in which the pain is happening. You would ask the patient to describe the pain, and you want to look at their skin color to determine oxygenation and perfusion. If they begin to start to turn purple or blue, then you know that there's a lack of perfusion. In addition, we would want to check the patient's heart by examining the EKG or ECG. This would give us a clear indicator to identify the rhythm. So in order to identify or treat Torsades de Pointes, first you have to see the rhythm on the EKG. And as previously mentioned, it will indicate that the patient will have a heart rate between 200 to 250. Then you would indicate that there's an irregularity. You won't be able to see the P wave, so there's no P wave, and the QRS will be widened, which in this case, like I said, the patient has a QR wave of 0.56. Then you would want to place the patient on a cardiac monitor to monitor the rhythm and the heart rate. In addition, you would want to prepare the patient and assist with a synchronized cardioversion. So with the cardioversion, you're going to give the patient 50 to 200 joules. That's like a low-grade shock, and this will help to get the rhythm back to normal. Then you would want to administer supplementary oxygen as prescribed by doctor. And in this case, with patients in Torsades de Pointes, if you could feel a pulse, then the magnesium sulfate that they would receive would be 1 to 2 grams IV in a 10 mils dextrose 5 water over 5 to 60 minutes. Then after you give this dosage, then you would follow that by 0.5 grams to 0.1 grams of magnesium per hour. In addition, you would want to administer anti-dysrhythmic drugs as prescribed by the doctor, and you would educate the patient on the signs and symptoms of Torsades de Pointes. Like you would want to let them know if they start to feel chest pain, palpitations, dizziness upon standing, if they faint when they go into the bathroom, or they can't walk for a long period of time without fainting, then you would want to let them know what to look out for.